Welcome to the AETCM, the Emergency Medicine channel. Shall I?
Yeah.
Today I'll be presenting a case of 53-year-old male who presented to our ER with complaints of sudden onset of shortness of breath, and patient was initially taken to an outside hospital from where he was found to have desaturation and referred to our hospital on 5-liter O2.
Okay.
So on initial assessment, patient was conscious and oriented, and on coming to the airway was patent. There was no secretions, gurgling or pulling of saliva.
Okay.
Coming to the breathing part, patient had a respiratory rate of 32 per minute, and a patient was having a saturation of 95% at 5-liter O2. And airway was bilaterally equal and normal vesicular breath sounds.
Okay.
Coming to the circulation part, patient had a pulse rate of 106 per minute with a BP of 140 ATmm Hg, and at this time we had connected the patient to cardiac monitors, and also we had put an 18-gauge cannula.
Okay.
Coming to the disability part, patient was having a GCS of 15 out of 15. Okay. Pupils were equal and reactive to light, and on exposure, patient was afebrile and was having a GRBS of 205 milligram per deciliter.
Fine.
So after the initial primary assessment, we have just reassessed the patient.
Okay.
Patient was tachypnic, but patient was maintaining a saturation of 95% with 5-liter O2. Okay. And BP was also maintaining, BP was 140/80. Okay. So at this point of time, we had asked to take an ECG, and the ECG showed a sinus tachycardia, and also there was S1Q3 changes in the ECG.
Okay.
With a RBBB pattern. Okay. So we had also asked to get an ABG since patient was tachypnic and having desaturation. Okay. And it turned to be a VBG on taking, but it showed a pH of 7.26 with a PCO2 of 50.2 and a bicarb of 21.8. Patient also had a lactate of 5. So at this point of time, we had arranged for a screening echo, and in the screening echo we were able to see a dilated RA-RV. There was no features of pericardial effusion, and we also had done a lung point of care. There was no presence of any B lines. There was no features of consolidation like starry sky appearance was not there. There was also no effusion collection as such. Bilaterally, there was no any effusion. So at this point of time, we had sent all the blood routines. Along with that, we had also sent the D-dimer, cardiac enzymes, and the pro-BNP.
Okay.
So we had also ordered for a chest X-ray. Now coming to the sample history, right. We had a 53-year-old male whose known case of hypertension and dyslipidemia who developed sudden onset of shortness of breath 3 hours prior to the presentation to our ER. Okay. And patient was also complaining of heaviness over the central chest region. Patient did not have any radiating pain.
That chest pain also started simultaneously, or?
Yes, along with the breathlessness, it has started. And it was not radiating. Patient didn't have any radiating pain, any sweating history or syncopal history. Okay. There was no history of any fever, cough. There was also no history of any chest trauma. Okay. So, but patient gives an history of slip and fall 3 weeks prior, and then patient was evaluated in an outside hospital, and there was an undisplaced fracture of the right lateral malleolus, and there he was conservatively managed by applying a below knee cast slab, and then patient was immobilized. There was a history of immobilization. And then on the day of presentation, due to the severe breathing difficulty and chest discomfort, patient was initially taken to an outside hospital, and from there he was having a desaturation. Okay. So initially he was started on O2 support of 5-liter O2 via facial mask, and then referred to our hospital. Okay. So on reaching our hospital, on general examination, there was no pallor, icterus, cyanosis, clubbing or lymphadenopathy. On chest examination, the air entry was bilaterally equal. There was no any normal vesicular breath sounds was present. Right. On CVS examination, S1, S2 was heard. There was no murmurs. Per abdomen, it was soft and non-tender. And on CNS examination, there was no focal neurological deficits. Okay. Coming to the medical history, patient is known case of hypertension since last 5 years and also has an history of dyslipidemia. There was no history of any previous DVT. Okay. And coming to the past history, there is no previous history of any DVT or hypercoagulable states, no history of any past malignancies, anything. Here we had initially taken the ECG, which had a S1Q3, and also it was showing sinus tachycardia with RBBB patterns. Echo was also having an RA-RV dilatation, which was more favor of pulmonary embolism features. We had also sent the D-dimer, and meanwhile, since the features were correlating with pulmonary embolism, we had given injection heparin. 5,000 international units was given, and also we were monitoring the BP. So the patient was holding the BP, there was no BP fall. So we had planned for a CTPA for the patient, and then we had mobilized the patient for the CTPA.
Okay, let's wait here. So here we have a definitive inciting history, right? Which, I mean, we have come to a diagnosis. I think there is no confusion regarding the diagnosis. It's going to be most likely a pulmonary embolism, right? So from the history, we definitely have something which can be equated as a provoking event, right? While presenting, the only thing probably you can add is, like you told, the patient is on this much liter O2. What was the PO2 by FiO2?
Actually, the blood gas analysis came to be VBG.
You should go for arterial blood gas in this scenario, and also talk about the absolute hypoxemia here. Okay, fine. Then on we moved on, and you didn't. Okay, ECG is also you told.
There was sinus.
What is the most common ECG finding usually?
Usually we get a sinus tachycardia.
That's
most
enough.
common.
But here again, you are saying that you have found something which is very much said to be associated with pulmonary embolism. That's also fine. And then we have proceeded with the other lab investigation. The problem is what you told us with the heparin. So if at all you are suspecting heparin and you want to treat heparin, it is not 5,000 units sub-Q. You have to either give an IV infusion of heparin or start with low molecular weight heparin. That was the only contradiction there. But continue, and we'll come to the discussion part later.
So we had mobilized the patient for the CTPA,
right.
And the CTPA came to be as acute saddle thrombus involving both left and right pulmonary arteries with extension. There was focal subpleural ground glass opacities in bilateral lower lobes, and it must be mostly related to the poor perfusion secondary to the thrombus. And there was also straightening of intraventricular septum with reflux of contrast into the IVC and hepatic veins suggestive of RV strain. So then patient was since there was acute saddle thrombus bilaterally and features of poor perfusion, patient was taken for a thrombolysis. So we had thrombolized the patient with alteplase. So we give a dose of 100 mg. So initial 10 mg bolus was given, and the rest of 90 mg was given over 2 hours, and patient was thrombolized. Following that, patient was also started on the heparin infusion for the 24 hours. Then later patient was changed into the oral coagulant, that apixaban was started for the patient.
So now let us discuss acute pulmonary embolism in detail. So what is the usual classification, like what do you follow?
Initially we used to follow the we used to look for the well score in the patient, and well score we have mainly will be looking for the features of any signs of DVT. If the patient have any signs of DVT, score of 3 will be given. Then if our primary diagnosis is pulmonary embolism, again a score of 3 will be given. If the heart rate is more than 100, if there is an history of immobilization for more than 3 days or any surgeries, then again a score of 1.5 will be given. If any previous DVT is there, also again a score of 1.5 will be given. Then any history of malignancy or hemoptysis, again a score of 1 will be given. So total score of more than 6 we have severe risk. Then score of 2 to 6 will be categorized as moderate, and less than 2 will be mild. So we will be categorizing into mild, moderate and severe. And then according to the modified well score, a score more than 4 can be taken as most likely to be a pulmonary embolism, and less than 4 can be taken as less likely. Also, we have the new score of PESI score, that is we will be looking for the parameters such as age of the patient, the sex of the, that is if it is a male sex of the patient, will be giving 10 points. Then comorbid illness will be looking into, that is if the patient is having any malignancy, a score of 30 will be given. Heart failure, score of 10, and any chronic lung disease, a score of 10 will be given. We'll be also looking into the clinical findings such as the pulse, BP, respiratory rate, temperature, and the arterial O2. So each of these will be given scores, and then we'll be classifying into class 1, 2, 3, 4, 5.
Right.
And class 1 will be a score less than 65. Class 2 will be 66 to 85. Class 3 will be 86 to 105. Class 4 will be 106 to 125. And Class 5 will be more than 125 score. And according to these scores, we'll be telling about the 30-day mortality. Class 1 will be having a 1% mortality. Class 2 will be having 3.1%.
Right.
Class 3 will be having 6.5%. Class 4 will be having 10.4%. And Class 5 will be having 24.5%.
Okay. So this is with the classification and prognostication. But from a practical point of view, what we need to understand is this is going to be a high risk PE or a massive PE, right? So you have two classifications upfront. That is the European Society of Cardiology and AHA classifications. European Society of Cardiology classification will be you have the high risk. Almost like your European classification of high risk and massive pulmonary embolism overlaps. So that is if the patient has hypotension. That is when, or the patient is in cardiac arrest or hypotension, is when you equate it as a high risk PE or a massive pulmonary embolism, right? Then in European classification, the next part will be your, what is next? Intermediate, high risk, intermediate, low risk, and low risk. So what we are really concerned about is the high risk PEs, where we need to probably end up resuscitating the patient also, okay? And it will be in the intermediate risk where you go for the echo evidence and things like that, okay? So what is the usual echo thing which we should be looking at it?
Usually in echo there can be changes of RA, RV dilatation can be there. Also there can be regional wall abnormality, motion abnormality can be there, which will be sparing the right ventricle apex. Sparing can be there.
Okay. What is TAPC? Tricuspid annular plane systolic escalation. No. It is basically you go for your 4-chamber view, place the probe and isolate and centralize your tricuspid valve. Okay, then you go for the M mode. In the M mode, you basically measure the nadar and the low. Okay, in that normally it is usually more than 17. So basically that is going to be your indicator of the right heart function, right? RV. Okay, so this is called as TAPC. Whatever else remaining, your qualitative assessments, the other named signs does not hold good. In ER, the recommended thing is to measure the TAPC, right? Okay, so you go for the echo. What is the other sonological thing which probably you should have done in this patient will be the Dopplers. Okay, here we may not be, because our suspicion is here we are not expecting a PE without a DVT. What we are expecting is a DVT most likely which has embolized, right? So definitely a lower limb Doppler is something which could be done in ER. Okay, so that is with the sonological examinations, right? So in ECG is what we just touched upon. What are the other things in ECG?
ECG most commonly will be finding of sinus tachycardia, right? Can be there. Then there can be also right axis deviation can be there.
Right.
RV-BBB with the RV strain pattern can be there. Then most common arrhythmia associated will be atrial fibrillation also can be seen there. T-wave inversions can be seen in from V1 to V4 can be there.
Any other labs which probably will help?
D-dimer can be also sent. It is a negative predictor value. If it is coming as negative, then we can rule out pulmonary embolism. That can be
other
sent.
labs, any role for cardiac enzymes?
Cardiac enzymes and pro-BNP also can be sent.
Definitely. Those are all supportive kind of things, like your anti-pro-BNP and TROPICE can be sent. Even though it may not support our decision making, those are more like a additional investigations which probably will help, right? So you have this patient, you initially took the history, everything, all points you had covered. From the examination point of view, we have done with an ultrasonological examination and ECG also. And now we come up with a diagnosis of pulmonary embolism, right? So what in the management, what are the things which we need to be aware of?
In ER, basically, we'll be looking into airway, breathing, circulation only.
Okay.
So we'll be taking care of the breathing part.
Okay, let us just broadly classify into the first thing will be the hemodynamic support, right? So suppose this patient is in hypotension. Are you going to give volume?
Yes. First, initial management of pulmonary embolism, if the patient is having hypotension, will be fluid resuscitation. So we'll be giving fluid of 20 ml per kg bolus fluids.
May not be the right thing to do, right? So by giving a lot of fluid, you are not going to help this patient, right? So again, already your RV is dilated. So the ideal thing will be a small liquids of fluids. So most likely like 250 to 500 ml of fluids. Even this is one place where probably you can check for responsiveness based upon your passive leg raising. Right? You can do a passive leg raising, see whether when the venous return is improving, is the patient BP improving. So only a short IV fluid challenge is expected in this patient. After that, you have to directly move on to your inotropic
noradrenaline can be
choice again. Noradrenaline remains the first line of choice, but in a smaller dose. Because once you start increasing the norad dose, the high doses of norad, what happens? Increase in pulmonary vascular resistance. So again, that is not something which you are going to. So a small dose of noradrenaline followed by second line will be
if there is a cardiogen vaso.
No. Second line will be vaso. Again, there is role for adrenaline, dobutamine, and milrinone here. Right. So these are the 5 agents based upon the situation of the patient. We will be titrating and moving around. So first thing will be norad. Second thing most likely will be vaso. If not much of tachycardia, then probably we will consider adrenaline also. Dobutamine definitely has a role in selective patients, but dobutamine usually we started with noradrenaline. Again, a subgroup of patients probably milrinone. Okay, so that is your fluids is off, your inotropes and vasopressors are off. Then we will move on to probably this patient. Let us say this patient is gonna need an intubation. Okay, so what are the key things here? Say this patient is having hypoxemia first, and we are planning to thrombolyze this patient. Now the saturation is around 85-90. Patient is tachypneic. What will be the immediate choice of airway protection in this patient? Or oxygen, I'll frame it better. What will you choose? Like HFNC, NIV, mechanical ventilator. So this is one place where HFNC has a definitive role, because whatever other things, an increase in intrathoracic pressure is not something which we are wishing for, right? Why?
Because again, question.
Naturally. So this is a place where HFNC definitely has an added advantage. So hypoxemia, if the patient can be managed with HFNC and the interim you are planning for thrombolysis, probably that will be the first line of choice. Yes, definitely HFNC is failing and you are going to end up with an intubation. Then what are the sequence of events you are going to carry out? What will be your choice of drugs?
Initially you can give an induction agent and most you can go ahead with an etomidate.
So most of the patients death happens during intubation with PE. Okay, so here you have to give drugs which classically fall into the hemodynamically neutral group of drugs. The ketamine and etomidate will. Even an awake intubation is something which probably we will try for in pulmonary embolism. So just a shot of induction agent and directly intubate. And even longer paralytic agents usually we will try to avoid. Okay, so you intubated the patient now. From the ventilatory setting point of view, what are the key things you are going to keep in mind? You definitely don't want a very high PEEP, right? Even tidal volumes, our target tidal volumes is going to be something like 6 ml per kg. So something which is just enough to maintain oxygen levels and also prevent hypercarbia. Okay, so that is going to be your goal purely from a ventilation point of view. So now we have done with volume, we have done with inotropes and vasopressors, we have done with the airway and ventilatory part. Okay, now definitive therapies. So what are the 3 broad definitive therapies in pulmonary embolism management?
Basically, after the thrombolysis.
No. So one is thrombolysis. Second?
Then we'll have to go for the.
Okay. No, I am talking about the broad management principles. One is your systemic thrombolysis. Second is catheter related interventions, and third is surgical embolectomy. Okay. So our focus from a medical point of view is mostly with systemic thrombolysis. So what are the agents available for systemic thrombolysis?
We can go ahead with the RTPase. So usually we will be using with the Altiplase. If we are going with Altiplase, then we can give, usually the dosage will be 100 mg and initial 10 mg will be giving as bolus dose, and the rest of the 90 mg will be giving over the span of 2 hours. That is the dose with the Altiplase. Okay. Then we can also go ahead with streptokinase also.
Okay. Nowadays we don't use streptokinase. It's either Altiplase or tenecteplase. Tenecteplase again has a weight-based dose. That's the advantage of tenecteplase. If an obese patient and things like that, we can prefer for tenecteplase, which again the dose ranges from 30 to I think 60, 30 to 50 or 60. And the advantage is there we are giving it as a single bolus. It's not like an infusion, you give it over like 3 to 5 minutes. Okay, that is with tenecteplase place. The other situation is going to be you're handling a patient with pulmonary embolism in cardiac arrest. How are you going to manage that? Is your CPR going to be effective during
Thrombolize.
Again, along with CPR, that is a situation where probably you are going to give a bolus dose of. Here we cannot start the infusion and say we are going to finish off the infusion at 2 hours, right? So a very strong suspicion of pulmonary embolism. Already a patient known case of DVT goes into your cardiac arrest. You are justified in giving thrombolysis along with your resuscitation, right? So you continue with your CPR and you give the bolus dose of thrombolytic agent. In those kind of situations, again, how long are you going to continue with your CPR? So definitely, even though there is no definitive guidelines for that, the reasonable choice will be to continue CPR for at least 30 minutes after your thrombolytic dose. Okay, fine. Now, we discussed alteplase, we discussed tenecteplase. After that?
If thrombolysis, if there is any contraindication or failed thrombolysis, then we can go ahead with the embolectomy also, we can go ahead.
Okay. It's not just embolectomy, the broad thing will be catheter-based interventions, which has one is catheter-related thrombolysis. So basically you insert a peripheral catheter, go into the thrombocyte and do an intraarterial thrombolysis kind of thing, right? There again a smaller dose of the same thrombolytic agent can be given. Second will be a thrombus remover, extract the thrombus, right? Okay, fine. Then what will be the next step? Catheter-related interventions and
then surgical.
Okay, again there will be a subgroup of patients who may not improve just with thrombolysis, right? When the thrombolysis fails or there is a contraindication for thrombolysis, you move to either a catheter-related intervention or a surgical embolectomy, where you directly go for an open surgery where you open the vessels and do it. Again, a surgical embolectomy will be indicated if the thrombus is extending into your chambers.
Yes.
Okay, RAR. Okay, fine. Then, and along with that, you are starting the patient on
will be anticoagulation.
Okay.
So this patient was started on apixaban anticoagulation. Initial dose of 10 mg BD was started, and then it was tapered to 5 mg BD dose was started. So usually we'll be giving for a period of 6 months. We'll be giving anticoagulation for the patient.
Again, the duration is not always 6 months. Okay. Again, the classification is whether you know the cause of pulmonary embolism or not. If it's a provoked embolism or not.
Provoked.
In a situation where you know that definitively the patient had an embolism following a surgery or a trauma, probably 3 months will be the minimum period in which you are going to give. Okay, after that, that will be the point where you are going to reassess and decide whether you are needing to continue the thrombolysis. A patient with malignancy, ongoing malignancy, probably they will require a longer duration of thrombolysis, right? And what's the advantage of apixaban over warfarin?
Monitoring less.
And even initiation with warfarin, you are going to need to bridge, right? You start with both heparin and warfarin and then change over. So definitely DOACs, direct oral anticoagulants have an edge over warfarin nowadays. Okay, that's it, right? So you want to summarize like what happened and
so in this patient, basically after doing the CTPA, we had taken for the thrombolysis, and following thrombolysis, patient was kept on heparin infusion for the next 24 hours. And then we had started the patient on apixaban, and then following that, patient was better. After the thrombolysis itself, following 1 to 2 hours, patient got symptomatically better. And then patient was discharged and then called up for the review basis.
So from ER perspective, one thing you need to remember is a proper sonological testing, which is not limited to your RRB dilatation, okay, which includes a thrombus scan, usually involves a detailed echo with your Doppler screens, okay. And also don't be hesitant to go ahead with a CTPA in patients with suspicion. And don't, for all practical purpose, let us not depend too much on D-dimer. Okay, we have a strong suspicion, echo evidence is there, clinical history is there, definitely go ahead with the CTPA, and based upon the CTPA, you plan for the next things. If the patient is, we have a suspicion, patient is in hemodynamic compromise, definitely there's a strong indication for thrombolysis in ER itself. Okay, right.